Good evening, everybody. My name is Dr. Halter, and I will be giving you this presentation this evening. And what we're going to be talking about today is reading between the lines, how to understand the raw EEG or the EEG, the squiggly lines, and how to, from there, decide what neurofeedback protocol to use. So we're going to look at symptom-guided neurofeedback and how that differs from actually using QEEG-based or QEEG-guided protocol selection for neurofeedback. After that, we're going to go into why getting a brain map, which is also kind of tied into that. After that, we're going to go into understanding the EEG. So what do the squigglies tell you, or those lines that are in each chart? And from there, we're going to go into real EEG versus artifact. And then after that, we're going to talk a little bit more about QEEG-based versus QEEG-guided and what it means to read between the lines and understand what we see. And after that, we're going to go into a little bit about how to select a protocol using the EEG that you then have collected. So symptom-based versus symptom-guided. Again, if we look at something, for instance, this map right here, we could just look at the neuroanatomy or use a handy map like this. And just, if somebody tells us what the symptoms are, then we can go according to the symptoms and then just, train whatever channels are indicated with whatever frequencies. So that is actually how some people do neurofeedback. They just have a symptom checklist, or they have the history of a client. Then, they look at the neuroanatomy, they have the understanding of that, and then from there they decide, okay, this area is underactivated or overactivated, and from there they decide what protocol to use. Well, a lot of times that can be done. However, a lot of information is missed doing that because, again, we do not see the actual activity that's going on in the brain. And a lot of clients aren't really fully aware of what symptoms they're really experiencing. So again, that can be one of the issues with this type of symptom-guided EEG or neurofeedback protocol selection. So why should we get a brain map, or do a full EEG that then tells us what protocols to select? Well, it gives us real answers, and it's a whole person approach. We see the entire brain, and again, we can then also determine what the actual sources of certain activity, or where certain activity is the strongest, or what kind of activity is contributing to certain symptoms. And again, getting a full brain map will actually make that more easier to do. Again, that way we can optimize the brain, and we can also, because there are certain times when, even though a protocol is appropriate for certain symptoms, other things should be looked at first. For instance, if the emotional centers of the brain aren't, the person has some kind of anxiety or other types of issues, but they come in for attention problems, then working just with the frontal cortex or some kind of neurofeedback to work on attention won't be as effective because, again, if the underlying cause is the emotional areas, then working with just the frontal cortex will not suffice. Again, all these things that you see here are great reasons for why we should do a full brain map. So what do these squigglies say? Well, in order to understand that, we have to understand what we're looking at. So this is what makes this a little bit more in depth and a little bit more complicated than just looking at symptoms and let the symptoms guide the protocol selection. So as we know, EEG is a non-invasive technique that lets us measure the electrical activity of the brain by the use of electrodes that we have in certain locations. So the EEG, if we look at it, it is full of real activity, real brain activity, and then there's also artifact. And again, we have to differentiate between those two. So what we first need to understand is what locations are those sensors attached to on the head. And again, we see that F is for the frontal areas, frontal pole is FP, then central is C, T temporal, P parietal, O is occipital, odd numbers on the left side, even numbers on the right side, and all the Z channels are the vertex. So again, knowing that where the locations are, we can now know what information or what data we're actually looking at when you look at the raw EEG. From there, we then have to decide, okay, what montage is being used? Is it a bipolar or referential? Bipolar looks at a chain of channels, where a channel is the active electrode in one pair, and then the next pair it changes, and it's now the reference electrode. And so that is a good way for us to really localize certain types of activity, because wherever we do see this type of phase reversal, when we use this type of montage, we know that that is the area that's closest to the activity in question. So again, understanding what montages we're using is also important, because that lets us know what the arrangement is that we're looking at on the screen. So from there, we can then use different montages depending on where the activity is. We can use the circular bipolar montage, if the longitudinal bipolar montage, if we run into this end of chain phenomenon where, for instance, in this picture here to the left, FP1 doesn't have any channel to compare to, so we're missing a potential phase reversal. So it's hard to localize it if we just use that montage, the longitudinal bipolar. But by switching to a circular bipolar or transverse bipolar, we can eliminate all that problem. But again, we have to understand what montage or what arrangement of the electrodes we're looking at. Then there's also these other referential montages. We have the linked ears referential montage, which the ears are the actual real reference. However, there's also virtual channels that can be used as a reference. For example, in the top on the left here, we have the average referential montage. And then we have the Laplacian montage on the bottom here. Again, the average reference montage compares all of the channels to a collective average, and the Laplacian only compares each channel to the ones immediately around it. So again, that is the difference between those two. So we also can understand then that the average reference montage is not able to localize information as well as the Laplacian. And that is just because in one case, you have a smaller number of channels to which each channel is compared to versus all the channels. So again, understanding the montages and when to use them is key in this process as well. In addition to that, we have to understand what the different frequencies mean or what they're associated with. We have to understand what the infralow frequencies are: delta frequencies, theta, alpha, beta, and gamma. And the reason for that is because, of course, all these different frequencies don't just look different, but they also have a different kind of association with what kinds of activity they're associated with. So from there, once we understand what the arrangement of the electrodes is and we understand what the different frequencies look like, we then also have to look at the background EEG and how it's organized. So when we look at organization, we mainly consider the continuity, symmetry, and anterior-posterior gradient. And continuity refers to waveforms being uninterrupted by periods of flat or very attenuated activity. For instance, the top image right here, that will be continuous. Then discontinuous, of course, you see this attenuation or a suppression of the activity. And healthy individuals should have a relatively continuous record. Of course, there are some changes. It shouldn't be the same route, but it should be relatively continuous. Then the next aspect of organization we look at in the background EEG is symmetry. So again, it should be relatively symmetrical from left to right. And healthy EEGs are relatively symmetrical, and intermittent or persistent asymmetries can arise when we see, for example, structural issues, for instance, tumors, encephalopathies, bleeds, or a history of TBIs. Most healthy individuals have a relatively symmetrical EEG, so if we see asymmetry, like in the lower image right here to the left, we should definitely make note of that, because again, that could be an issue with some kind of structural issue with the brain, or possibly some thalamocortical communication issue with between the cortex and thalamus. but that is why we look at symmetry. Then the next piece of organization or portion of organization in the background EEG that we need to look at is the anterior-posterior gradient. And of course, we want to see more faster frequencies and lower amplitudes in the front, and higher amplitudes and slower frequencies closer to the back. Especially with the eyes closed condition, that's usually what we expect to see in a healthy individual. We also need to look at the posterior dominant rhythm, which is usually somewhere between 8.5 to 12 hertz. And again, having a posterior dominant rhythm is one of the key aspects to look at in the EEG, because it's associated with a lot of, with the brain, how fast it communicates, and also what capacity it has to communicate with the other parts of the brain. And so knowing that is quite important. And if there's a difference between the two sides, like the left and right side, that is greater than 50% in amplitude or 1 hertz in frequency, then that is also usually an indication that there may be some kind of issue. In addition to that, we then also look at the background variability and reactivity. So again, we don't want no reactivity or variability. We want there to be a certain amount of variability and reactivity. So especially when it comes to variability, a normal brain should have regular fluctuations in waveforms from second to second. So relatively consistent, but just minor changes and fluctuations. So that would be normal variability. When it comes to reactivity, that's more a response to external stimuli. So if you're not having a person do an ERP assessment or some kind of task, then reactivity is not necessarily something that you would expect unless you see somebody who's drowsy and then somebody knocks on the desk, and then you see alpha appearing back in posteriorly. So that would be an indication of reactivity. So again, we want that to be visible in a normal or in a healthy individual. Then the final aspect of background EEG that we need to consider is the state of consciousness. So again, most of the time with an awake EEG, we expect to see mostly alpha and beta activity, and there shouldn't be very much delta activity in the background in an adult eyes open, eyes closed EEG at all. So again, that is one thing that we look at, but we also look at, for instance, drowsiness. We look at if there is this slow roving eye movements at FP1, FP2, and F7 and F8. If we see that, that's an indication of drowsiness. Also, if we see the alpha frequencies posteriorly change to theta and then to beta, and basically the alpha drops out, that is another indication that a person has entered a different state of consciousness, namely light sleep or first stage of sleep. And so now that we know how the different sensors are arranged montage-wise, and we understand what the frequencies look like, and we understand the background information of the EEG, we can then move on and look at what is actually going on. So as you can see, a lot of information needs to be taken under consideration when we look at an EEG. And so far, as you've noticed, we haven't looked at anything except for the raw EEG, or talked about anything but the raw EEG. So now that we have this EEG, we can look at, possibly treating all these different disorders. But here's the thing: we don't see disorders in the brain. So what do you do? Well, first we have to, before we go into that, we'll discuss a little bit more about real EEG or artifact. To determine that, there are 4 main things we can look at. One is field. So is it in just one channel, this activity, or is it somewhat also, can it be seen in other channels, especially those close by? So that will be field. Then phase is the activity that we see in one similar to activity in another channel. So again, that would be phase. Then we also look at location, because that tells us if something is an eye blink or something else. Because again, eye blinks are generally the strongest in the front. So that's where location matters. Then frequency matters as well, because of course, where do we see most of the muscle tension? Usually in the frontal areas, the posterior areas, and the temporal areas. And so if we see high frequency activity, we need to think, oh, could this be muscle tension? Again, so that's why field, phase, location, and frequency are the 4 aspects that we can use to determine if something's real or artifact. So let's try this out. So right here, we see that these activities both have field and they both have phase. But what is real and what isn't? Well, here is where the location really matters. So as you can see, the image to the left here, the strongest activity of this is in the front. Well, where the eye is located, where the eye blinks located, in the front. Whereas here in this other image right here, you see all this activity that looks somewhat similar, but it's throughout the entire brain. It's seen globally. And in fact, in the frontal areas, there's only one channel where it's pretty high, and the other channel, FP1, is not so high. So again, location matters. And so we see field and phase. So both of these are activity that we see. An eye blink is considered artifact. This activity isn't considered artifact. It is actually real activity, real EEG. That, again, is the type of activity that we would refer because, again, it is something that is not normal activity. So when we see this, we don't want to throw this away because we think it's eye blinks. That's why we have to go through these different aspects of determining if it's real or not, because otherwise we throw it out and it could be real activity that we really have to think about or think about referring to somebody else, because otherwise they won't get the help that they need. So again, understanding what you're looking at is really important. So again, make sure you understand those 4 different components of what a real EEG is and how to distinguish that from artifact. Here's another example. So here to the left, we have this activity at F8. It's very pronounced, yet the areas close by, so let's say F4 or C4, yes, we see something, but again, it's not even that those activities that we see at C4, they're not even in phase with that activity. So more than likely, this is a wacky electrode. So that is how I would determine that this location or this activity, again, it doesn't have field, it doesn't have phase. So those are 2 things that are already missing. And then again, that's why this is more likely it is some kind of artifact. However, when we look to this image to the right, we see that these are channels F7 and T3. Well, F7 and T3 are relatively close together. So if we look at this activity, it looks very similar. Of course, there's some differences in the 2 locations, but in general, we see very similar activity. So that activity has field, and it also, since it's in 2 channels that are close by, and it also has phase, as you see that a lot of this activity happens at the same time in both locations. So again, looking at field and phase. And now we're going to talk a little bit about QEEG-based or QEEG-guided EEG, or how to look at an EEG and from there decide what protocol to use. And one thing that I love about Jay Gonkelman, he always has really lots of wisdom to share with others. And again, he stated that nothing beats the visual inspection of the raw EEG. And I tend to, up to this point, unless our AI improves a lot, so to this day, I think this is largely true. So when we look at depression, so the diagnostic criteria would be more than 5 symptoms during the same 2-week period that are changed from previous functioning, that also involve depressed mood and the loss of interest or pleasure. Then we exclude symptoms that are clearly attributable to other medical conditions. Well, do we see this in the brain? Well, unfortunately, we do not see how long something has been there, or how long some activity has been there, or how it affects the person necessarily. However, we do see some things in the EEG. And as you may remember earlier, I said we don't see disorders in the EEG, but we see certain kind of electrical activity that is consistent with certain symptoms. So what does it look like in the EEG? Well, let's take a look. So when it comes to depression, so again, we see up here FP1 and T3, and also at F7, we see this slowing. So in the front left of the brain, we see slowing. And again, we see this kind of suspicious activity here, but again, it's sort of a slow wave activity. So we have this slowing that's happening in the front of the brain and at F7. And again, we also see that there is at CZ some slowing, but also some excess beta activity. So again, if we see slowing on the front left and we see some slowing in the center, then that is an indication that, yes, that is consistent with somebody who is in a depressed mood or in a depressed state. Of course, that's not all we look at, but it's what we look at EEG-wise. It is consistent. So when we look at the FFT spectrum, we can then actually corroborate what we saw in the raw data. So here at around F7, we see this excess of theta and alpha activity. And then centrally, we see an excess of the slow activity as we expected, but also this faster activity. And that is also what we saw in the raw EEG. So again, this is consistent with what we see in the QEEG. So the quantitative metrics is consistent with our hypothesis of what we saw in the squiggly lines. Then when we look at the Loretta images, we see that that activity is exactly what we thought it was. And this tells us exactly where the source is. Again, centrally and to the right, there is excess slow activity. Of course, there's also excess fast activity, but we're mainly concerned about this excess slow activity. So again, here's another individual. And again, we see the slowing at F7, so frontal left. Then we also see some slowing at temporally at T4. Again, so let's see if we can confirm that with our FFT spectrum. Oh, and we also see this kind of this more pronounced alpha activity down in the posterior areas. So when we look at the FFT spectrum, again, it confirms exactly what we thought. Excess theta we see on the left side, on the right side of the head. Then we also see this excess slow activity here at F7, and that's what we saw in the image. Now, we also should have to understand that we have to make sure that that slow wave activity is actually real activity. The best way to do that is to make sure that if you see that when you're recording, you can make sure that it's actually real activity and not just some kind of poor impedance or some other issue with the sensors. So, and then we also see posteriorly here, or at T6, we see an increase in the alpha activity right here. So that's exactly the kind of thing that we expected to see. Then when we look at the Loretta source images, we see again that posteriorly there's too much slow wave activity, as well as here on the side, and also here at F7 again, as well as the central areas. So again, consistent with depression. Then we also, here we have another image of an individual, also within the same category of depression. But again, we see that this person has frontal slowing that is throughout almost the entire frontal areas, and also posteriorly. So in general, the temporal and central areas aren't quite as bad, but in the front or the back, we see quite a bit of slowing. And also some hyperconnectivity. It's as you can see, let me go back. the phase, so all this activity is also very much in phase with each other. So frontally, as you see, these are all, they have also a lot of activity that is very similar in phase throughout the front. And then we see that as well in the back. So when we look at the FFT spectrum, we see this. Again, we see the frontal and posterior areas where there's excess coherence. And again, if we look at the FFT spectrum, if we just look at the frontal channels, they all look very similar. Then also the posterior channels look very, very similar. So again, that tells us that there's hypercoherence in the front and in the back. Again, we also can look at the connectivity maps, and we see that what we expected was, we see in the alpha activity, hyperconnectivity in the front and in the back, and throughout most of this headspace. So again, that is how we confirm what we see in the raw data, and we can actually, look at the quantitative metrics to make sure that what we see is really the way it is. So then now we're going to look at ADHD. So the diagnostic criteria: 5 or more symptoms of inattention and or 5 or more symptoms of hyperactivity or impulsivity must have persisted for greater than 6 months to a degree that is inconsistent with the developmental level and negatively impacts social and academic or occupational activities. Several symptoms, inattentive or hyperactive or impulsivity, were present before the age of 12 years, and several symptoms, inattentiveness or hyperactivity or impulsivity, must be present in 2 or more settings: homeschool, work, with friends, relatives, or in other activities. So again, as you can see, this is a very complex kind of criteria. Well, a lot of this stuff we don't see in the brain. So what is it that we do see in the EEG? Here it is. So you may be looking at this and you may be wondering, well, I don't know what I see here. Well, if you look at these 3 channels right here, F3, FZ, and F4, you may notice that, again, you see this in-phaseness of these channels, mainly F3 and FZ, but also to a certain extent F4. Then in addition to that, so again, this person's brain, the frontal areas are locked. So that's what that tells us. So then we also see at C4, we see this type of alpha variant, which is the mu rhythm. Again, that is usually what we see if somebody is basically checked out and not really available emotionally or in any other sense. And so again, that is what we see in somebody that is with attention, or potentially see with somebody who has attention issues. But the main thing to look at here is this, again, this hyperconnectivity or hypercoherence or too much phase of these channels. And it's throughout, as you can see, throughout this whole record right here. So when we look at this FFT spectrum, it shows us exactly what we see, what we saw. So at FZ, or F3, FZ, and F4, these locations, we saw this excess slow activity, but it's in all 3 locations. Then we also saw this over at C4, which we see right here. So again, this is exactly what we saw in the raw data. Then we can also look at this activity right here, which again is exactly what we saw in the raw EEG. Again, we see this the slow wave activity that's in the front, and that is again then what was consistent with attention issues. Again, too much theta, slow wave activity in the front can oftentimes lead to attention issues. Also, it could be that the person isn't fully recovered or isn't sleeping well. So again, if we see something like this, like what we would call a vertex wave right here, that is usually something we see in in stage 2 of sleep. So if we see it in somebody who's awake, that may be an indication that their person has a sleep issue. So if you see this vertex wave, think possible sleep disorder, sleep apnea, narcolepsy, sleepwalking, and so forth. And that alone can also, if somebody isn't fully recovered, again, as you may know, if somebody is tired, fatigued, again, their ability to attend or for them to attend and process information is not as effective as if they would be sleeping well. And again, we see a lot of hyper or in phaseness, way too much hypercoherence that we see in some of these channels. So then the next thing we're looking to look at is intermittent explosive disorder, or some kind of recurrent discrete episodes of aggressive or impulsive behavior toward other people or property. Now, we don't see that in the brain. That is something that is a behavioral indication that somebody has some kind of concern, but what does it look like in the EEG? So let's take a look. So for instance, if somebody has a temporal issue, like a T4, because that's where the emotional memory and all that stuff is taking place, we see slowing there. We also see excess fast wave activity. And we see that in both, again, this is a father and a son. So it's very interesting how sometimes we see similar activity in relatives. But that same activity can lead to the same kind of emotional issues that the son and the father both have. So then now if we look at major neurocognitive disorders, or something that would tell us if there's some kind of impairment, a cognitive impairment, well, again, we don't really see the behavioral aspect of it in the EEG, but what do we do? What do we see in the EEG? Well, what we see is we see this excess slowing at both the left and the right side. So that excess alpha activity, again, is an indication that there could be some hyperperfusion or maybe some kind of slowing that, if again, could be an indication that somebody is in the early stages of dementia or has some kind of cognitive issue. And again, if the brain slows down, obviously it's not going to work as effectively and as efficiently as if it didn't slow down and it is firing in the normal frequencies. So again, that's what we see in the EEG. And then when we look at the FFT spectrum, it is exactly what we suspected, this excess alpha activity temporally. Then when we look at the source, the Loretta source images, we see that, again, left and right side and this excess slow activity, the source of which is both in the left and the right side. So what should we consider when developing protocols? The first thing is, once we do the assessment and we meet with our client, so the way that I do my assessments is I have someone else collect the self-report measures or all the measures that we use to do a match of the EEG once we've done the analysis. But I don't look at it until I'm done with the analysis of the EEG and the raw data. And I do that because I don't want to be biased, and I want to keep myself from being biased as much as possible, because I don't want me knowing what a certain person's concerns are to influence what I'm looking for in the EEG. So, but that said, after I've done the analysis, the first meeting with the client, I assess, okay, how is this person relating to me? How am I relating to the person? Again, you get kind of an idea of you want to establish rapport. So again, that is one big important consideration. Also, that is when we look at the medical, nutritional, psychological, psychiatric, legal history of the individual, and probably not during that session, but before that session. And again, those things can then determine, okay, with this background that this person has, what would be an appropriate training protocol or process to use. Then also, what other assessments should I do or should I have done? just the QEEG, or should I do a stress profile, interview, cognitive testing, functional medicine, and observation? My recommendation is that the more objective data you can have to triangulate where the person is in their experience of whatever the activity in question is, then the better you're going to be able to develop a protocol. Because if I have just the EEG, I can't do anything really, because I just know that the person's brain is functioning a certain way. But unless it's connected to some kind of a symptom or goal, then I can't really do much with it, because again, it could be a compensatory function or something else that's going on in the brain. And again, so that is one important thing to take under consideration. So collecting, for instance, cognitive type of test that measures, processing speed or attention capacity or attention speed, those kind of things would also be helpful, or like in using ERPs as well. So again, consider what kind of assessments are necessary for the population that you're working with. Then also, in your conversation with the client, is the client ready to really take this training seriously? There are some people who are just not ready. If a person is struggling with, for instance, finances, and they're anxious, and then putting them into this kind of process that requires extra time or finances may make the person even more anxious, and so it may be counterproductive, or the person may not be open about certain concerns that they have. For instance, when I worked with soldiers, a lot of them weren't willing to say that they had any kind of sleep issues, or that they had any kind of emotional issues, or that they had any kind of drug or alcohol issues. So again, understanding how open the person is and how willing they are to work with you is also very important. Also, consider the person's lifestyle. You don't want to assign any kind of homework assignments that don't fit the person's lifestyle. They're not going to, even if they do start the training, they may not be compliant with any kind of homework assignment you give them, because it just isn't something that fits into their lifestyle. And again, I'm not saying, you can't make any demands on the client, but again, we should make enough of a demand to have them be able to do what we assign them to do, but also we should make it as feasible for them as possible without putting them out. So when it comes to protocol selection, then one thing to consider is, should we use neurofeedback alone as a standalone intervention? And again, depending on the condition or the symptom or whatever it is that the person is being trained on, neurofeedback may be perfectly fine by itself. But then you also have to ask yourself, should I use biofeedback, such as heart rate variability metrics? Should I look at muscle tension, temperature, and so forth? Also, should I use any of these other types of neuromodulation devices? Then also looking at somebody's medications, and, if a person isn't on medication, would that possibly help the person? Are they on supplements? How is their nutrition? Then are they going through some other types of physical therapy or functional medicine? And those are all different aspects to consider. Again, before I do any type of neurofeedback or biofeedback, I usually have the client rule out anything that could impede the progress. For instance, if somebody isn't sleeping well, or doesn't have a well-structured or a well-in-place circadian rhythm, whatever we do, biofeedback or neurofeedback-wise, is not going to be as effective. Also, if somebody's a history of TBIs, then if that person may have some kind of hormonal issue, for instance, they may not even get into any kind of deep sleep, or even if they do, their brain may not, or the pituitary gland may not release enough growth hormone. So again, ruling out that it's a hormonal issue is very helpful, because then we can just go forward with the protocol that we determined based on the EEG and the person's symptoms. and we don't have to worry about if any of these other physiological or these other areas of their life are impeding the progress. So again, that's important in selecting a protocol. Then, as I said, client openness and willingness. So when it comes to protocol selection for QEEG-guided neurofeedback, in the assessment, I do some eyes open and eyes closed for about anywhere from 5 to about 12 minutes, depending on the goal or the purpose for my assessment. Then again, I take all these different things that we talked about, the raw EEG, the patterns, background, and amplitudes, transients, spikes, coherence, and relationship between channels, medication, what the history is, what bipolar or referential montage I'm looking at, whether I'm going to look at just the EEG or just do neurofeedback, or am I going to look at other modalities of training as well. So then I also take under consideration, what is it that the person was diagnosed with? Well, so what's in a name? What is in depression that I actually see in the EEG? What it is in any of the disorders that we look at that I can actually see in the EEG? So that's how we need to approach it. We can't just say, okay, I want a fingerprint of what it looks like if the person has depression. Well, who knows if that is exactly what you will find? Because usually finding every single symptom of a certain disorder, or even a cluster of symptoms, may not be what you find. What you can find is electrical activity. You have to understand what the structures of the brain, what kind of electrical activity, if the electrical activity is dysregulated, what that could mean based on the underlying structures of the brain. And also, there is no one size fits all. Everything should be customized to the individual's brain maps and other objective metrics, and matched with their experience or their endorsement of certain symptoms. And then look at all the different variables. This is like putting together a crime scene. So you don't just want to look at one or two variables. Look at all the things, all the variables that you have in front of you. And from there, you then pick the location. Once you know what location it is that you're going to train, look at what type of frequency it is that you want to enhance or decrease or change, or do you and then understand, okay, I know that it's this location and that location that I want to train, and I want to increase this frequency or that frequency. That's how you can then develop the protocol. So go about that way, and you'll find that whenever you do neurofeedback training, it is a lot more effective than if you just decided to look at one or two variables and then you're missing a whole bunch of other information. Or if you just look at it as a certain type of disorder, and you know that somebody else has used a certain protocol for people who have this kind of disorder, and then you use it. Well, that may not fit to what the person's brain is actually telling you. So again, looking at all the variables, looking at the brain is extremely important. Then also, if you see some of the activity, like some of the activity we saw today, that could be epileptiform in nature, or some kind of seizure activity, just refer. Don't tell the client, hey man, I think you have a seizure. That, again, not the right way to go about it, but you can tell an individual, look, there's some activity that I see in your brain that I would like to have somebody else review, or that I would like to refer you to someone else to review this or to look at this activity. So again, whatever way you put it, make sure it's something that the person can actually understand, and you don't put that person into a mode where they think, oh crap, I have epilepsy or whatever. So again, refer when needed. Also, integrate other domains. For example, nutrition. Have a nutritionist, or have the person see a nutritionist. If they're, again, if they're in some kind of, again, if they're not exercising, exercise can make a big difference in how they feel, as well as how their brain functions. Also, sleep, nutrition, and then so all sorts of other interventions that you could integrate, or photobiomodulation, or TCDS, or looking at audiovisual entrainment. There's all sorts of different other types of interventions that can be integrated together to give you the biggest bang for the buck. And so think about what is it that it can do to help this person out to the greatest extent. Don't just think neurofeedback protocol. Think, is there anything else that the person can do that will make their neurofeedback more productive and more effective? So what we went through today is, should we look at just symptoms to guide our neurofeedback, or should we look at a full EEG? What are the advantages of looking at a full EEG? And then once you realize that there are advantages of using a full EEG, then what do I do? Like, what do I look at? So then we go into what is it that you need to know about the EEG. So we went through all the different background information. We went through knowing the difference between artifact and real activity, what the different criteria you can use to determine whether it's real or whether it's artifact. Again, those are the things we talked about. Then we talked a little bit about what certain types of some of the more common diagnoses and what it is that we actually see in the brain that is consistent with that type of a diagnosis. Again, remember, we do not see diagnoses or disorders in the brain. We see certain activity that is associated with certain type of symptoms. So again, that's what we look for when we look at the EEG to guide our protocol for neurofeedback. Again, making sure that the client making sure that we've taken all the information after we analyze the EEG to put together a comprehensive plan for an individual is ideal. So don't just think neurofeedback, don't just think therapy, don't just think biofeedback. Think bigger. What can the person do outside of the office or outside of neurofeedback and biofeedback to actually get us closer to that goal? So that is it for my presentation, and I just want to review some of the upcoming courses that Successful Practitioner and InMindOut are offering. So next month we're gonna be in San Antonio, and again we're gonna on the 18th and 19th we're gonna go through biofeedback. Then the 20th and 21st we have a neurofeedback class, and then on the 22nd and 23rd we have a QEEG class. And then on the 24th and 25th, we have advanced EEG again, and then again on the 26th, we have a QEEG mentorship day. And again, all of these classes are, the biofeedback and QEEG class, they're all, they follow the blueprint of the BCIA and IQCB. So again, if you're interested and if you like this presentation, we have a lot more and a lot of great stuff to show you all in our upcoming classes. And then below that, you see the November series. And again, if you have any questions, just go to Successful Practitioner and their website, and you can talk to Kelly. He's great to talk to. He's a great person. Very nice, very fun to talk to. And if you have any other questions, just feel free to contact Kelly, or you can contact us at InMindOut.